Good evening, everybody, and welcome to the Resident Smart Learning Program. Today we have topic is on PUJ obstruction, diagnostic algorithms and management, which will be done by Dr. Surya Prakash, who's a senior consultant at the Yashoda Hospitals, Hyderabad. This is a very important topic for both clinical practice and for the students for the exam. You will definitely get a pediatric case or an X-ray or something where you will have to deal with this subject. So I hope it will be useful for all of them. Now I would request Dr. Arun Chawla to take over and introduce the speaker and then moderate this session. Over to you, Dr. Arun.
Thank you, Dr. Keshav. It's indeed a great privilege in introducing one of our senior member of USI, Dr. Surya Prakash, who is faculty for today's very important smart learning program on the topic of UPJ, covering the diagnostic dilemma as well as management issues. Dr. Surya Prakash is MBBS with the gold medal to his credit from Karun Medical College, alumni of MS General Surgery from PGI Chandigarh, has the distinction of having the FRCS to his credit from Edinburgh, and he did his MCH Urology from Nizam Institute in Hyderabad, and has also finished his diploma at National Board in General Unit Surgery in year 2005. In 2016, he has finished his diploma in laparoscopy and urology from Strasbourg, France. Presently, he is working in a very famous hospital, Yashoda Hospital in Hyderabad, and he is a visiting faculty to MPUJ Nadia. In his career of more than 20 years, he has worked as different places in different positions, right from Narayana Medical College in Nellore, in Nizam Institute in Tirupati, as well as Virinchi Hospital in Hyderabad. He is has got the honor of starting the renal transplant program in the Narayana Medical College Hospital and Manipal Hospital, Vijayawada. Extremely talented and gifted surgeon, very good in his work, very versatile. His area of domain covers pediatric urology, reconstructive urology, endourology with stones and TRP, and the lab and robotics. And a man with great knowledge in all the areas of urology. He has been faculty to the zonal as well as the national conferences in various positions, has done many courses also, and it's a great player in having him today for a very important class. As Dr. Keshav was telling that how important is PUJ, whether you take adult PUJ, you take a pediatric PUJ, it always throws some question in the theory or in the practical in the form of quad round, short case or long case. What he is going to give a clear messages on what to do, what combination of investigation you should do if you are suspecting PUJ. Ultrasound with some imaging, whether it's a nuclear imaging or a contrast-based imaging. If it's a contrast-based imaging, what is the current role of IVU? Is always a CCT or some MRI? All this area is big touching. In pediatric, is it different, or adult it is same? So he'll be clearing your doubts from that, and he'll be briefly touching about the what management strategies, what are the principles of managing surgical management of Piloplasty, of PUJ obstruction. So, my dear residents and the members, if you have any question, you can put in the chat box. He will take after the class is over. And I urge you to stay active during his presentation. And if you have any question, please try to answer if he's asked. Thank you very much. And over to you, Dr. Surya.
Thank you, sir. Thank you very much for the kind introduction. At the outset, I would like to thank Dr. Keshav Murthy, sir, USI, and Dr. Arun Chawla for giving me this opportunity. I really appreciate them for starting this great program, which is very useful for the postgraduates. I really envy the present postgraduates because during our days, we didn't have so much of learning. So I hope all of you make use of this resident learning program. So the topic Dr. Arun Chawla sir has asked me to speak is on uretropelvic junction obstruction. Sir, is my slide visible?
Yep.
Yeah. as he has already pointed out to you, this is a topic which is more often asked in the practical examination. So you should know all the intricacies. Though its topic looks a little straightforward, there are so many practical questions which will be asked in the practical exam. So we'll touch most of these controversial things. So to start, as you all know, this is the most common pathological cause of antenatal hydronephrosis, and the incidence is about 1 in 750 to 1,500 live births. Though primary UPGO is a congenital condition, we usually see these conditions in adult patients also. And rarely we come across PUJ obstruction, asymptomatic PUJ obstruction, even in elderly patients. In the last 2 decades, there have been many changes in the management of this condition. The open surgery has taken the backbench. The laparoscopy and robotic have come forward, and they've become they've replaced the open surgery. And even the endourological procedures, which once we thought they're not of great success, again they have come into the front field. So we'll be talking about all these topics. So in the next 45 or 50 minutes, I'll be talking to you about on these topics: etiology in clinical presentation, role of various diagnostic modalities. When do we do these different investigations? Indications for intervention, management, follow-up. How do you define whether your Piloplasty is successful or your procedure has failed? And with the procedure has failed, how do you manage these patients? So coming to the etiopathogenesis, we'll be confining our discussion to the primary UPGO, that is which is an intrinsic disease. Though you know the UPGO can be a secondary because of some injury or some extrinsic compression. The primary UPGO has got is hypothesized to have many causes, like aperistaltic segment at the UPJ, which doesn't allow the peristalsis to go from the pelvis into the ureter, which is thought because of the replacement of the spiral musculature by the fibrosis and the longitudinal muscles. And it has also been thought that there is a decrease in the density of interstitial cells of Kajal at the UPJ, which are thought to be the pacemakers cells which initiate the action potential, and they are responsible for the initiation of the peristalsis in the UPJ area. And another thing which is caused is the kinks and valves, which are nothing but the infoldings of the ureteral mucosa and the musculature. Because of these things, when these kinks and valves are the cause, we give time for the child to grow and thinking that these infoldings may straighten. So this is one of the reason for the conservative management of the UPJ in pediatric age group. And high insertion of UPJ is another cause, and crossing lower polar vessels. Crossing vessels were initially thought as a cause, but later they said they are innocent bystander. The pathology is is because of the aperistaltic segment. Again, there are both ways of thinking. Now, we have come across many cases where the crossing vessel is actual culprit, which is a cause of the obstruction. So I'll be showing one of the videos. So when we talk of crossing lower pole vessels, the crossing lower pole vessels causing the UPJ are seen in up to 60% of the patients with UPJ. It's not a small number, it's a significant number. So a point of word for your examination, when you talk of crossing vessel, you have to tell whether it is a multiple renal artery, is it an anomalous or aberrant vessel, or an accessory vessel. So you should know the difference between these terminology. So I'll define these terminology. If the kidney is supplied by more than one artery arising from the aorta, you call it multiple renal artery. You don't call it accessory. So if the vessel is coming from other than aorta or the renal artery, suppose the vessel is coming from inferior mesenteric artery or a splenic artery, then you call it as an anomalous or an aberrant vessel. If the same renal segment is supplied by more than two or more arteries, it is called accessory vessel. So you should be very clear when we use this terminology. I mentioned because here there is a vessel separate from the renal artery, which is thought to be the cause of obstruction. So here you can see in this picture, there's a crossing vessel. This vessel can directly compress the UPJ, or it can be an innocent bystander where the pathology is in the intrinsic or in the PUJ, because as I told, other causes. And when the pelvis enlarges because of the obstruction of the PUJ, pelvis enlarges and overhangs over the vessel, and appearing that the vessel is a cause. So both are possible. Vessel acting as an innocent bystander, and vessel itself causing the obstruction in a normal PUJ. Both things are possible. So, having learned about the causes and etiopathogenesis of the UPG, how do these patients present? It can be an asymptomatic diagnosis when you do investigation for some other cause. Just do an ultrasound and you just find a PUJ in a patient. It can be asymptomatic. And in pediatric age group, they can present with a palpable abdominal mass. You can find a palpable hydronephrotic kidney. And patients can present with a pain, intermittent dull aching pain. That's the most common presentation. And the other presentation is a Dietz crisis, usually seen in intermittent hydronephrosis, partial PUJ. When the kidney is stressed because of hydration, patients will present with pain because of hydronephrotic kidney. It's called Dietz crisis. They can present with hematuria, grossly hydronephrotic kidney. It can bleed with trivial trauma to the loin. Child can present with hematuria. On the hydronephrotic kidney, when it gets infected, the child can present with fever and the loin pain. And obstruction can lead to stones, the secondary stone, that can be another presentation. In bilateral UPJ or UPJ in a solitary kidney, they can, in the late stages, can present with renal failure. There's other type of presentation. And hypertension is also supposed to be one of the presenting manifestations of the UPG. So how do we evaluate these patients? Before we go to the investigations, a word about the clinical examination. In adults, your clinical examination may be normal, but in pediatric age group, you should always examine. They can present with a palpable abdominal mass. And don't forget to examine the genitalia, because these congenital anomaly can be associated with other anomalies. We have seen undescended testes, hypospadias, other congenital. So you should not forget to examine the child. In full examination has to be done. So what are the investigations? The list goes like this: ultrasound, intravenous urogram, CT IVU, MR urogram, and diuretic clinogram. So we'll discuss what each investigation play a role in the diagnosis of UPG obstruction. Ultrasound, this is now in exam it is said as the extension of physical examination. So it is a cornerstone in the radiological evaluation of renal obstructive disorders. It is non-invasive, inexpensive, portable, and there is no ionizing radiation. These are the advantages. Of course, it does have some lacunae, like it is operator dependent, and in obese patients, it's difficult to visualize the kidney, and overlying bowel gas can again obscure the visualization of the kidney and the UPG. So what do you see when doing an ultrasound in these patients? You see the location of the kidney, size of the kidney, architecture of the kidney, echogenicity, corticomedullary differentiation, thickness of the parenchyma. In hydronephrotic kidney, there can be parenchymal thinning of the parenchyma. Whether it is hydronephrosis, what is the grade of hydronephrosis as per SFU grade? Is the ureter dilated or not? And if it's a hydronephrotic kidney, are there any secondary stones? Are there any internal echoes which suggest infection? All these things have to be seen. Apart from the affected kidney, we should also examine the normal kidney. Is it normal or is there any compensatory hypertrophy? So all these things have to be examined when we do ultrasound. So in pediatric age group, we know in adult kidney, we know the normal length and width of the kidneys. In pediatric age group, there are certain nomograms. So, and you should compare the findings, what you get with the nomograms, to know that whether the child kidney is of normal length or whether it increased because of hydronephrosis. You can see here the nomograms for age, length versus age, and as per the height, the length of the kidney, and as per the weight, you can see the length of the kidney and the body surface area. For example, you see in a 6 months old child, the length of the kidney should be maybe around 5.5 centimeters. Similarly, if you take a height of 70 centimeters, the kidney length will be again about around 5.5, 6. So you should extrapolate your results on these nomograms and see whether the child has got normal parameters or abnormal parameters. So you should all know about this grading. This is commonly asked in the exam. Society of Fetal Urology has come up with a grading of hydronephrosis. Grade 0, there is no hydronephrosis, no splitting of the central sinus echo. Normally, when we do an ultrasound, the sinus complex is echogenic because of the presence of fat and the vessels. It looks bright, and the parenchyma looks little hypoechoic compared with the central sinus. and there is a splitting of the central sinus, you see a little hypoechogenicity, that is called grade 1 hydronephrosis. And grade 2 is further dilatation of the pelvis and dilated calyces. It is grade 2 hydronephrosis. Grade 3 is dilated pelvis and dilatation of all the calyces. From grade 2 to grade 3, the parenchyma is normal. When there is a thinning of the parenchyma, it is called grade 4 hydronephrosis, or as per the SFU grade. So when we do ultrasound, we should not get confused with the renal pyramids. Renal pyramids also look hypoechoic, but they do not connect with the pelvis. So they are placed in the cortex. So I think you should all be familiar with doing renal ultrasound and identify hydronephrosis and normal architecture of the kidney on an ultrasound. So one common entity which you can miss as hydronephrotic kidney is the MCDK. So how do you differentiate MCDK from a hydronephrosis due to PUJ obstruction? So on ultrasound, so in PUJ obstruction, the hydronephrotic, the dilated pelvis is seen as a large medial sonolucent area. You can see in the picture, this is the pelvis, which is surrounded by the dilated calyces, which connect to the renal pelvis. This is very important. Dilated calyces are connected to the pelvis, and this is surrounded by the renal parenchyma. And when we do a Dtpa in these patients, you see some amount of functioning renal tissue. Whereas in MCDK, there is a haphazard as an arrangement of the cysts. You can see some large cysts in the peripheries, small cysts in the center, and there is no communication because there are cysts. There are not calyces. There is no communication among the cysts, and usually these MCDK kidneys are non-functioning, and hence rarely you see any parenchyma in these kidneys. And the Dtpa doesn't show any function. This is how you differentiate MCDK from the hydronephrotic kidney caused by UPG obstruction. So apart from the parameters, what I have told, there are other parameters which you do by using ultrasound and which help in the diagnosis of UPG obstruction. One among them is the resistive index. So you know the formula how resistive index is calculated: peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. So whenever there is an obstruction, it causes an increase in the intrarenal arterial resistance, resulting in the reduction in the diastolic flow. So when there is a reduction in the diastolic flow, obviously the RI increases. So the criteria for obstruction ultrasound is RI greater than 0.7. Normal RI is 0.7, 0.6 to 0.7. If it is more than 0.7, an interrenal RI difference, the RI from normal affected kidney to the normal kidney, this is called interrenal RI difference, is more than 0.06 to 0.1. Again, criteria for obstruction. And abnormal RI response to diuretic challenge. And you give Lasix and check the RI increases. So this is the abnormal RI response to diuretic challenge. A word of caution is infants tend to have high RI values compared to the adults. So if you find some RI of 0.8, sometimes it could be normal in the pediatric age group. So these are for adults. So another parameter in ultrasound which can suggest obstruction is renal parenchymal longitudinal area or divided by the renal pelvic calcial area. So if it is less than 0.1, less than 1.6, it is predictive of obstruction. So the renal parenchymal volume can be calculated by ultrasound, and with the 3D ultrasound, you can better calculate the parenchymal area and the pelvic calcial area. And it has been said that the volume calculated with the 3D ultrasound correlated well with the volume calculated when compared with the volume calculated by the MR, and it is also almost equal to the differential renal function by renal scintigraphy. So after discussing about the ultrasound, now comes the intravenous urography and its role in PUJ obstruction. So traditionally, in our training days, all patients with the pelvic aortic junction obstruction undergo an IVU. Nowadays, this is not a commonly done test. Why? We'll discuss that. So when we do an IVU, there is a delay in the extrusion of the contrast. You see a hydronephrotic kidney has a dilated PCS filled with contrast and normal caliber ureter. Obstruction doesn't mean that the contrast doesn't come into the ureter. You always see a ureter with contrast because this obstruction is not absolute. Even in a severe hydronephrotic kidney, it's a partial obstruction. So what are the limitations of IVU? The diagnosis is difficult in poorly functioning kidneys. The kidneys doesn't excrete the contrast properly. You cannot diagnose on IVU. And bowel preparation is necessary because the overlying bowel gas can obscure the kidneys. And vascular anatomy, like as we discussed, the crossing vessels cannot be seen in IVU. And it is difficult to assess the cortical architecture. The parenchyma, thinning of the parenchyma, architecture of the parenchyma cannot be seen. And IVU can miss radiolucent secondary stones. And in anomalous kidney like malrotated kidneys, ectopic kidneys, again, you can't delineate the anatomy well on IVU when compared to the CT scan. So nowadays, the standard IVU or traditional IVU is replaced by the CT urogram. In CT urogram, again, like in IVU, you see a dilated pelvic calcium system with a non-dilated ureter and abrupt transition at the pelvic-ureteric junction. This is the characteristic of UPG obstruction and diagnostic. This is the modality of choice for differentiating UPG obstruction from other causes of hydronephrosis and also from other conditions like parapelvic cysts and cystic disease. Crossing vessels, parenchymal abnormalities, secondary stones, anomalous kidneys with UPJ are all better visualized on CT compared to a traditional IVU. And moreover, the 3D reconstructive images give an excellent anatomy of vascular anatomy and the parenchymal anatomy when we do a CTU. But what are the limitations or the problems with CT aerogram or radiation dose? You know, the radiation dose is very significant compared to our IVU. And there is a cost involved when we do a CT urogram. And in children, we need to anesthetize the child. So when we do a CT urogram. So this is how the pelvic ureteric junction obstruction look like. You can see the thinned out parenchyma, dilated pelvic culture system. The affected segment also can be visualized. The crossing vessels can be visualized with the CTS. Nowadays, it has become the imaging modality of choice after the ultrasound, and it has almost replaced the IVU in most of the centers. So next coming to the diuretic clinogram. Diuretic clinogram helps in estimating the differential renal function and also the severity of the obstruction. So any case where there is a worsening of the renal function, now it is taken as indication for intervention. So what are the indications for diuretic clinogram in UPJO? It helps in the diagnosis. That means it diagnoses the obstruction and also the function of the kidney and also estimates the function of the kidney. It helps in follow-up of the patients who are on conservative management. You keep the patient on follow-up and to see whether the child, the renal function is maintained or not. So we do a follow-up renogram to see if there is any worsening of the renal function. It also helps in the post-op assessment. You have done a Piloplasty and you want to know whether your Piloplasty is successful or not. You do a renogram in the post-op to see the drainage and the function. So these are the three indications of renogram in PUJ obstruction. In exam, you can be asked, is renogram a mandatory test after ultrasound? And if suppose you have done an IVU and a CT IVU, is renogram mandatory? It is not mandatory, but you can substantiate by saying that it can quantify the function. And any worsening function, normally we take as 35 to 40% as the cutoff. And if the function is less than 35% in the follow-up renogram, that is an indication for obstruction. And it also helps as the baseline study, and which helps us in following up the patients after the surgery. So it is not mandatory, but gives it more information in characterizing the obstruction. Of course, I'll come to you in the later on about the investigations which we do. We don't routinely do a CT urogram in pediatric age group. We just do an ultrasound and a renogram. So a few slides about diuretic renogram basics. So radiopharmaceutical is given in diuretic renogram. Radiopharmaceutical is a combination of radionuclide. The radionuclide commonly used is the technetium-99. The combination of technetium-99 with the pharmaceutical is called radiopharmaceutical. The renal handling of the radiopharmaceutical is dictated by the biochemical properties of the carrier molecule. The commonly used radiopharmaceuticals in UPG obstruction are MAC3. Of course, MAC3 is not available in India. In our centers, it is usually done by EC, that is ethylene dicysteine, or Dtpa. Dtpa is most commonly used radiopharmaceutical in many centers. So how are these pharmaceuticals are handled by the kidney? MAC3 is principally cleared by tubular secretion. It is used for renography. Whereas DMSA, which we don't use for diagnosing UPG obstruction, it localizes and binds in the proximal convoluted tubules. It is basically used to assess the parenchymal function for renal parenchymal imaging, like in pyelonephritis or vesicoelectric reflex to see for any scarring. DMSA is used. And Dtpa is mostly it is cleared by GFR. Again, it is the isotope of choice for renography. So EC, ethylene dicysteine, Dtpa, and MAC3, these are the three radiopharmaceuticals used for UPG obstruction. So these are the tubular agents. EC and MAC3 are the tubular agents. They are preferred over DTPA because of greater renal extraction, lower background activity, and higher kidney to background ratio. So if there's a lot of background activity, it is difficult to draw the region of interest. So we need an agent which is primarily concentrated in the kidney with a less of background. So in younger children, agents with greater renal extraction like EC and MAC3 are preferred over DTPA. And it can be asked in the exam at what age the renogram can be done in a child. If you are using EC or MAC3, the study can be done even in a neonate at the 1 month age. The study can be done. Like MAC3, EC is cleared by tubular secretion. So what are the basic differences between MAC3 and DTPA? MAC3 is majority is bound to plasma proteins. It's principally cleared by tubular secretion. And nearly 50% of the radiopharmaceutical given is extracted by the kidneys. It shows both parenchyma and the collecting system well. It gives an excellent functional quantification. The radiation dose is very less, and the current agent of choice for evaluating the function and drainage. EC has got almost similar characteristics compared to the MAC3. Coming to DTP, it has got very little plasma protein binding. The renal extraction is less compared to MAC3. There is only 20%. Because the renal extraction is less, there is a lot of background activity. It is cleared almost exclusively by the glomerular filtration. It has got excellent visualization of pelvic calcium system. The results are suboptimal in immature kidneys and in patients with low GFR. So whenever we do a renogram, we have to answer the most important question, that is why we are doing this study. And to get maximum information, we have to pass on certain information to the nuclear physician, like congenital anomaly. Suppose you are doing you want to do a study for a pelvic ectopic kidney, and this information has to be passed on because the gamma camera can be positioned according to the location of the kidney. And any previous intervention, presence of catheters, PCN or stents, any stones, status of the overall renal function, other associated comorbid conditions, or have to be assessed. We have to know, and we have to pass on this information to the nuclear physician to get the proper information from the study. So how does this study is done? Briefly, the study is done like this. The child or the patient has to be well hydrated with about 500 ml of fluids given orally over 30 minutes preceding the study. The patient should void before beginning the study. That means the bladder should be empty. It is done in a supine position with the camera under the table for posterior images. The field of view includes kidneys in the urinary bladder. The radiopharmaceutical, either it is MAC3 or EC or the DTPA, is injected as IV bolus. Initially, the serial images are taken at 2 seconds per frame for 60 seconds to evaluate the renal perfusion. This is followed by images at 1 minute. Every 1 minute, the images are taken for 20 to 30 minutes to evaluate the function and the obstruction. And at the end, the child is the osteovoid and the static post-void images taken. So basically, there are two phases when we do a diuretic renogram: the perfusion phase and the functional phase. In the perfusion phase, we see the perfusion or the flow to the blood flow to the kidney. In the perfusion phase, images are acquired every 1 to 2 seconds immediately after the IV bolus injection, and the region of interest are drawn over the aorta on the each renal unit. So the data are recorded as activity per unit time and plotted on a time activity curve. So the shape of the curve of each kidney is interpreted. So you can see in this renogram, on the top right corner, this is the perfusion curves. This is the aortic curve. This is the left renal perfusion and the right renal perfusion. The normal renogram, you see, this is a normal kidneys, and the perfusion appears like this. These are the curves taken when the pharmaceutical has come into the kidney. That's why the aortic curve appears little flat. Here you see, and then on the right side, you see a kidney where there is a left kidney, the function is less and is obstructed. And you see, they correlate with the perfusion curve. Compared to the right kidney, the perfusion in the left kidney is less. So this shows that we have to see not only this excretion curves, also this perfusion curve. And so this shows that the perfusion is less compared to the normal kidney. So like our excretion curves, there are curves for perfusion also. There are 4 types of curves. How they are interpreted? The type 1 curve, the aortic pressure, this is a normal curve. Type 1 is normal curve, and it looks like this. These are the normal perfusion curve. The aortic pressure is greater than renal artery pressure, which is again greater than the segmental artery pressure. This is how normal perfusion, normal pressures are there. In type 2 curve, this is the type 2 curve, the aortic pressure is greater than renal artery pressure. Renal artery pressure is greater than or equal to segmental artery pressure. In type 3 curve, the renal artery pressure is greater than or equal to, aortic pressure is greater than or equal to renal artery pressure, and the renal artery pressure is equal to the segmental artery pressure. It's almost, it is now, see, there's not much of upsloping. In type 4 curve, all the pressures are equal. That means that very high intrarenal resistance. The segmental artery pressure, renal artery pressure, and the aortic pressure. Almost the segmental artery pressure is equal to the aortic pressure. There's not much of perfusion in the kidney. So the perfusion curve looks like this. These are the perfusion curves on renogram. So coming to the second phase of renogram, there is the functional phase. In functional phase, the images are acquired at 1 frame per minute, and the relative function of each kidney is determined by measuring the area under the time activity curve between 1 minute and the 3 minutes. So the curves of each kidney are roughly parallel in shape and magnitude. The split function difference of up to 10% is considered within normal limits. Suppose the right kidney is 40 and left kidney is 50. The difference of up to 10% is considered normal. More than 10% is abnormal. The normal kidney will spontaneously clear the tracer in 15 minutes. So sometimes there can be delay in the clearance. When there will be delay, when there is an obstruction, or when the system is grossly dilated. Even non-obstructed, grossly dilated kidney will have a delay in the clearance. So how do we differentiate whether the dilatation is because of obstruction or because of some non-obstructive pathology? That is done by giving a diuretic. That means you stress the system and see for the drainage. So in diuretic renography, we give the diuretic Lasix. There are many protocols of when we give the Lasix, whether we give after the radiopharmaceutical or before the radiopharmaceutical, when both are given simultaneously. When both Lasix and radiopharmaceutical are given at the same time, it is called F0 protocol. When Lasix is given before, it is called F- protocol. Usually it is given 15 minutes before the radiotracer. This is usually done in a grossly hydronephrotic kidneys where we expect some amount of diuresis, or poorly functioning kidneys, we do a F-15 protocol. F+15 protocol is in this, the Lasix is given 20 minutes after the radiotracer. So the dose of Lasix is 1 milligram per kg in infants and 0.5 milligram per kg in children and adults. So after giving the Lasix, we see for T-halves. What is T-half? So we measure two parameters, T-max and the T-half. T-max is the maximum tracer uptake, and T-half is half of this T-max to clear, the time taken for T-max to reach half. That is the T-half. So if the T-half is more than 20 minutes, it suggests obstruction. If the T-half is less than 15 minutes, that is considered as normal. And if it is between 50 and 20 minutes, it is considered as equivocal or indeterminate. So the criteria for obstruction or diuretic renography are the differential renal function of less than 35 to 40% with a T-half value of more than 20 minutes. So when we give Lasix, you can get these type of curves. In obstructed curve, there is no response to Lasix. The curve continues to be on a plateau mode. So when there is a non-obstructed dilatation, the curves goes down with the Lasix. Even with the Lasix, if it persists like this, that means it is equivocal or partial obstruction. So O'Reilly has described 4 types of curves in the functional phase, that is the excretory mode. They're called, you call them 1, 2, 3, 4, or A, B, C, D. So A is a normal curve, it's a rapid uptake, and the bell-shaped curve. The curve goes down normally. And the type B is an obstructed curve. There's a rapid uptake, and the contrast has come into the pelvic cell system, and it is not being excreted in the ureter. So you see a plateau curve. Type C is the dilated and non-obstructed curve. When we give Lasix, there is a drainage. Type D is a partially obstructed. Even after giving Lasix, there is some drainage, but it is not much compared to the type A or type C curve. So it's a partially obstructed curve. There is another type where there is a response to diuretic, the curve comes down and again starts peaking up. It's called Holmes' sign. Where do we get this? When there is an intermittent hydronephrosis or partial UPJ. So when a patient, usually patients with intermittent hydronephrosis present with episodes of intermittent flank pain, and when you do an ultrasound during the episode of pain, you will find hydronephrosis. So hydronephrosis is seen only during the episodes of pain, or on provocative testing by forced diuresis. This type of intermittent PUJ obstruction usually seen in the later period of life, and it flares up periodically until a irreversible obstruction finally develops. So this delayed double peak sign is characteristic of intermittent hydronephrosis. It's called Holmes' sign. The flow of what is the pathology or what is the explanation for this is the flow across the UPJ does not keep pace with the increasing in the pelvic pressure. Normally it goes, the drainage will be there, but when the pressure increases in the pelvis, the drainage decreases. Because the UPJ junction becomes self-obstructing as the pelvis enlarges. So the Rhinogram, as we said, it is very good investigation, but it too has certain limitations. When we do the Rhinogram in a poorly functioning kidney, it is not that informative because, as I showed earlier, you don't get a characteristic curves in a poorly functioning kidney. And in very capacious collecting systems, the radionuclide given is retained in the pelvis, and it can give a false estimation of high differential renal function. So again, another limitation is when a dilated collecting systems are included in the region of interest, the resulting rhinogram may be a false positive for obstruction. This is called reservoir effect. So there are certain pitfalls. Though it's a good investigation, it has got certain pitfalls, it cannot exactly characterize the severity of the obstruction. In a poorly functioning kidney, even if the obstruction is severe, it cannot characterize. And variable impairments of renal function. As I said, a normal functioning kidney and poorly functioning kidney can affect the interpretation of the rhinogram. And volume capacity of the pelvis. Small volume pelvis, large volume pelvis, again, the interpretation is difficult. It also depends on the hydration status of the child, as I already told bladder fullness. If the bladder is full and the pressure can be transmitted to the upper tracts, and again, it can affect the interpretation. Positioning of the patient, radiopharmaceutical given, region of the interest drawn, movement of the patient, dose and choice of the diuretic. These are all the parameters which will affect the final report, and the time at which the diuretic given and the method of the RETA interpretation. So many factors affect the final interpretation. This is why the nuclear physicians have come together and they have come up with a consensus like this is called a well-tempered rhinogram. So they have put certain norms. So this is the way the rhinogram has to be done in all institutions. Then only we can compare the different results. So what is a well-tempered rhinogram? When we do a well-tempered rhinogram, we should have certain prior information like ultrasound should be there, and this information should be passed down to the nuclear physician. And BCUG, if it is done, for some reason, it also has the information has to be noted. The minimum age is 1 month to allow for the renal maturity. And the serum creatinine level should be checked. Oral hydration starts 2 hours before and continued throughout. IV hydration also for children, 15 milligram per kg over 30 minutes before the injection of radiopharmaceutical. Bladder drainage is very important, especially in children. A Foley catheter or an infant feeding tube is placed. If you suspect hydronephrosis, it is preferable to put an infant feeding tube compared to a Foley catheter because the Foley catheter balloon can obstruct the ureteric orifice and can impede the drainage. So another advantage of putting a bladder catheter is it reduces the radiation to the gonads. And it also, when there is a proper bladder drainage, there is not much of movement of the child. And it also helps in assessing the drainage when the response to the diuretic can be assessed when we put a bladder catheter. So this is about a well-tempered rhinogram. This can be asked commonly in the practical exam. So we'll see some rhinograms and see how the interpretation goes. So here is a patient who has got like hydronephrotic kidney and ultrasound. And when we do a rhinogram, you can see, I'll just read out. You see the perfusion phase of the kidney. The perfusion and the initial dynamic images of the left kidney are severely decreased. The radio tracer uptake is also limited. There is a slow tracer transmit time from the cortex to the pelvic cell system. And during subsequent part of the study, slower tracer urine accumulation is noted in the renal parenchyma. The left kidney rhinogram curve shows severe blunting of the Tmax peak and slow rising curve pattern during the excretory phase of the study. So the delayed images taken till 4 hours show persistent hold up in the dilated PCS. So this is a poorly functioning kidney with not a classical curve, what we described. The type 2 curve is not classical seen, but in the later part, there is a persistence. You can see here, in the functional phase images, the delayed uptake of the contrast into the parenchyma and which continues to persist. So the interpretation is hydronephrotic left kidney with a severely impaired function due to outflow obstruction. Suppose you would operate this patient and do a renogram 3 months later, how does it look like? So this is a post-operative uranogram of the same patient. You see, if you see the curve, it looks like there's not much of change between the pre-op and post-op. But in the later phases, there is a delayed uptake, but there is a clearance. Even the perfusion also, not much of difference. So it is already in a significantly affected, damaged kidney. So what do the report reported as? There is a perfusion and initial dynamic images show severely decreased radiotracer uptake in the parenchyma. During the dynamic part of the study, there is a slow tracer urine accumulation in the dilated PCS, but the delayed images acquired till 4 hours show good tracer clearance. So that means the anastomosis is functioning well, but there's not much of a change in the function of the kidney because it's already a damaged kidney. So it's a small hydronephrotic left kidney with severely impaired function and non-obstructive pelvic LCL system. So whenever we see, you have to, apart from these curves, what are the other parameters you have to see? You have to see the GFR, you have to see the Tmax and the T-half. So this is another renogram. The obstructed kidney. You see, when the region of interest is drawn, this is a patient who has got an ectopic kidney. The kidney is located low down. The left kidney is lower down. So you can see here, we have to draw the region of interest here. Unless this information is passed on, if they draw the region of interest in the normal location, you get a report that it's a non-visualized or non-functioning kidney. So you can see the left kidney, it's an upgoing curve. The right is normal. Again, the perfusion is less on the left side compared to the normal kidney. So it's a hydronephrotic, ectopic, malrotated left kidney with mild impaired function due to partial but significant outward tract obstruction. So the T-half on the right side, it is 10 minutes. That means that in 3 minutes, you got the peak. And for the peak to become half, it took 10 minutes. That is within the normal limits. Whereas on the left side, the peak is reached at 25 minutes and the T-half is not reached. So this is how we have to interpret an obstructed curve. This is another patient, the preoperative renogram. You can see a right-sided upgoing curve, classical type 2 curve, hydronephrotic right kidney with moderately impaired function due to outflow obstruction. The relative function you see, on the right side it is 54%, left it is 46%. T-half is not attained on the right side. Left side, the T peak is reached in 2 minutes and the T-half reached at 8.5 minutes. So again, the same patient, renogram done after surgery. So you compare the curve pre-op to post-op. There is a rapid uptake and the downslope. That means our anastomosis, whatever we have done, is draining well. So what it is reported as enlarged hydronephrotic right kidney with maintained function and dilated non-obstructed drainage. In comparison to the previous study, there is the improvement noted in the right renal function, the drainage system. Now here you can see the T-half is at T peak is attained at 5 minutes and the T-half is reached at 13 minutes, which is normal. So this is a successful Piloplasty. So it's again another patient with an obstructed curve. You can see the left curve, which is going up, type 2 curve. Perfusion is maintained here. It's almost both right and left kidneys, renal perfusion is normal. And the T-half is not attained for the left kidney. The right kidney parameters are normal. The other patient is a 7-month-old child, upgoing curve. The differential function is maintained, 48%. T-half is not attained. Perfusion looks okay. This is the same child at 2 years of age. 7 months. These 3 renograms of the same patient. This is done at 4 months. You see, this is a 4 months renogram, and the child was managed conservatively. This is a 7 months renogram. Again, the curve shows upgoing curve, and at the end of 7 months, we took a decision to operate the child, the same child, and the renogram done at 2 years shows normal drainage. So when you keep the child and follow up, you monitor them by doing a renogram at 3 months. And on the follow-up renogram, you find that the function is decreasing or the obstruction continues to persist, then you operate. And this is the post-operative renogram showing the normal drainage. So now coming to the MRI. So what is the role of MRI? The newer modality called gadolinium Dtpa MRI. It gives an excellent morphological detail and functional information. So the morphologically, like any ultrasound or CT, you see a dilated PCS with abrupt transition of the UPJ. Functionally, we see a reduced enhancement, delayed excretion of contrast into the PCS, swirling of contrast, fluid levels in the renal. These are the parameters which we see in an MRI. And we can estimate the differential function and the renal transit time. This is called functional MRI. So in MRI, the differential renal function and the renal transit time, when we assess, they are almost similar to the split renal function, the T-half estimated with the renogram. So the differential renal function on MRI is determined when there is a homogeneous enhancement within the kidney prior to the excretion of the contrast into the collecting system. So similarly, like what we measure in Dtpa, we measure at between 1 and 3 minutes. Here, similarly, before the contrast comes into the PCS, the DRF is assessed. The renal transit time is the time between the appearance of the contrast in the kidney and the appearance in the ureter. So renal transit time less than or equal to 4 minutes is normal. More than 4 minutes, but less than 8 minutes is equivocal. If it is more than 8 minutes, it suggests obstructive drainage. So these are the parameters you see when we do a functional MRU in UPJ obstruction. So what are the indications for surgical intervention based on a gadolinium Dtpa MRU? Differential renal function less than 35 to 40%, same as a diuretic clinogram. Renal transit time more than 8 minutes. Prolonged corticomedullary crossover times, decreasing GFR associated with the anatomical findings of dilated PCS with abrupt transition of the UPG. So this is one test which though we don't do in our practice, can be asked in the examination. Antegrade pressure monitoring. It is called as Whitaker's test. So our pressure perfusion pressure flow test, where we put a catheter in the kidney and one catheter in the bladder, perfuse the kidney and measure the pressures in the kidney and the bladder. If there is an obstruction of the UPJ, as we perfuse the kidney, the pressures in the kidney will rise. This is the basic principle of Whitaker's test. So how the kidney is perfused, we can do a nephrostomy, or we can put a small microtip catheter for doing the study and infuse the PCS with 10 ml per minute of normal saline. And the bladder pressure is measured by a catheter transducer placed transurethral in the bladder. So the intrapelvic and the bladder pressures are measured. We can do a standard urodynamic setup. The differential pressures between the pelvis and the bladder are measured. So if the pressures are between 12 and 15 centimeters saline, it is considered as normal. If the pressures are more than 20 centimeters saline, it is considered as obstructed system. Between 15 to 20 is considered as equivocal or indeterminate. So a word about antenatal hydronephrosis. When we talk of the modalities of investigation in the neonates and infants, routinely we don't do a CT urogram. The standard investigations are ultrasound followed by a diuretic clinogram. So when we do an ultrasound in an antenatal hydronephrotic kidney, and after delivery, we don't do a scan immediately because of immediate dehydration. Sometimes we may not pick up the hydronephrotic kidneys. That is why we do at the end of first week a postnatal ultrasound. And on postnatal ultrasound, if there is no hydronephrosis and the pelvic diameter, anteroposterior pelvic diameter is less than 7 mm, then no need for any kind of intervention. Suppose if there is a mild hydronephrosis on an postnatal scan without ureteric dilatation, it could be a SFU grade 1 or 2. And if the APD, renal anteroposterior pelvic diameter is 7 to 10 mm, you can just follow the child with a renogram or an ultrasound. If it is a moderate to severe hydronephrosis, that means SFU grade 3 or 4, on the APD more than 10 mm, we do a MCUG. Or mild hydronephrosis with ureteric dilatation, MCUG is advocated. On MCUG, if there is no reflex, we do a diuretic clinogram. And if it is obstructed, then we take a decision based on the renal function on the T-half values. If there's a vesico-ureteric reflex, we manage accordingly. So this is the algorithm for antenatal hydronephrosis followed postnatally. So now, having discussed about all the investigations like ultrasound, traditional IVU, CT urogram, diuretic clinogram, MR urogram, now we come to the management. So what are the indications for intervention? The standard investigations are symptomatic UPJ needs intervention. The symptoms can be pain, hematuria, or infection. Can be an infected hydronephrotic kidney, impairment of the renal function, as I discussed, the deterioration of the function and a follow-up diuretic clinogram. Secondary stones, The rounded secondary stones, that means they are again the indication for intervention. Hypertension. So how do we manage this condition? Conservative. So partial UPGs, as I said, they can be managed conservatively, especially if you think it is because of ureteric folds or kinks. As the child grows, the kinks straighten up and the PUJ can be rectified. The endourological managements like antegrade endopylotomy, retrograde endopylotomy, endopyloplasty, these are the endourological methods. Operative interventions could be open, laparoscopic, or robotic interventions. The different types of procedures like dismembered Anderson-Heinz Pyloroplasty, non-dismembered techniques like Foley YV, Culp divide spiral flap, Scardino-Prince vertical flap, Electrocalycostomy, and of course, the non-functioning kidney, we may end up in doing nephrectomy. So coming to the conservative methods, when do we manage these children by conservative or non-operative methods? Or asymptomatic UPGO and partial UPGO. Usually it is done in infants and pediatric age group. The prerequisites are the child should have a normal, the renal function should be preserved. That is, the split renal function should be more than 40%. And the follow-up is done by a regular renogram. Every 3 to 4 months, do a renogram and see whether the obstruction is persisting or resolving. Coming to the endourological intervention, that is endopylotomy. This was once, in my training days, it was a very popular technique. It has lost popularity. Again, now we are seeing many patients undergoing endopylotomy. The word endopylotomy is coined by Dr. Gopal Badlani, the US urologist. The principle of endopylotomy is the full thickness lateral incision through the obstructing PUJ and the proximal ureter right out into the peripelvic or periureteral fat. Once you incise the UPJ up to the peripelvic fat, we place the endopylotomy stent and allow to heal. It is something like doing a VAU for a stricture urethra. And it is based on the principle of Davis intubated ureterotomy. So the endopylotomy can be done by a percutaneous route or by a retrograde route. The indications are primary UPJO, especially when the patient has got a secondary stones. You can puncture the PCS, remove the stones, and at the same time you can do an endopylotomy. It can be done as a salvage procedure following a failed Piloplasty. You do a Piloplasty which has failed, and we expect a lot of fibrosis at the UPJ, and endopylotomy is a alternative to salvage Piloplasty. There are certain limitations or contraindications for endopylotomy. They are long segment UPJ. Suppose the obstructed segment is long, these procedures, they do not work well. Crossing vessels, because there's a risk of injuring the vessels when we incise the UPJ. Infected kidneys, and of course, coagulopathies. These are the contraindications for endopylotomy. The access is usually through a mid-posterior or superior calyx because we want a straight access to the UPJ. If you puncture a lower calyx, it will be very difficult to reach the UPJ. So you have to, when you plan endopylotomy, you have to plan your access route to the UPJ. The PUJ can be incised by a cold knife or by a laser. Once we incise, we place the endopylotomy stent, which has got a larger caliber in the upper end and a smaller normal caliber in the lower end. It varies from 10 to 14 French, the upper end of the stent. So this is a small video clip of antegrade endopylotomy in a patient who has got a secondary stones. So here you can see the stones are being fragmented with the laser. Stones are being retrieved. You can see the PUJ here. See the ureteric catheter is compact. It is almost like snugly fitting ureteric catheters. And with the laser, holmium laser, we are incising the UPJ. So till you see a wide lumen and see the peripelvic or periureteral fat should be seen. So laser is an excellent modality to incise the PUJ. The incision is being carried down to the periureteral fat. We can place a ureteric catheter or a guide wire for access across the UPJ. In this case, we have put a ureteric catheter. So the incision carried down. See here, now we have completely inside. You can see the fat here. The mesh-like thing here, fat is seen here. So the incision has gone into the upper ureter a little bit. See, it's gone into the upper ureter. The fat is seen here. Completely PUJ incised. Now we put a guide wire. We place an endopylotomy stent. They allow it to heal. So the stent is placed usually for 4 to 6 weeks and then removed. So this is the endopyloptomy stent. The stent has got a larger diameter. That is a 12 French endopyloptomy stent. So the endopyloptomy can be done by retrograde route also, as I said. Here we can directly visualize the UPJ. A semi-rigid or a flexible ureteroscope be used. It can be passed up to the UPJ. A full thickness incision is given with a laser wire or a cautery wire balloon. So these are another technique which was very popular some time back, and it is now given up because of the advent of minimally invasive laparoscopic and robotic pyeloplasties. In this, like what we have seen earlier, an incision is given down up to the periuretic or peripelvic fat, and this incision is closed in a Henke-Mikulix fashion. The vertical incision is closed horizontally. So this is called endopyloplasty. So now coming to the Piloplasty, there are certain things which are commonly asked in your exam, whether will you do a retrograde Pylogram before Piloplasty or not. So the advantages of doing a retrograde Pylogram are it will delineate the UPJ segment. Suppose when you're planning open surgery, you can plan your incision based on the UPJ segment. It will also tell about the length of the segment in relation to the vertebra. What is the length of the obstructed segment, and the relation of the UPJ segment in relation to the vertebra also can be assessed. What are the concerns? Why some people that don't do RGPs, especially in pediatric age group, there is a risk of injuring the ureteric orifice, raising a flap at the orifice, and this can there will be difficulty in passing a stent, antegrade stent, while doing the Piloplasty. So when we do a CT urogram nowadays, you get all the information what a RGP gives. So that is the reason why sometimes we don't do RGP in treating these patients. If at all you do an RGP, it has to be done just before the definitive intervention, because there's a risk of introducing the infection if you do at sometime before the definitive procedure. So another question commonly asked is, if the patient has got UPJ obstruction, will you put a stent or nephrostomy and wait? So it is not a routine procedure. We do put a stent or a PCN and drain the kidney before the definitive procedure in certain conditions. Like if it's an infected UPJO or infected hydronephrosis, you don't operate these patients. You let the infection settle down by putting a stent. And if a lot of internal echoes, a PCN is a better drainage over the stent. And the patient has got azotemia because of a UPJ obstruction in a solitary kidney or a bilateral UPJO. In those patients, you drain the system by putting a stent or nephrostomy, let the creatinine normalize, and then you can do the definitive procedure. Or rarely, if the patient has got severe unrelenting pain, it's a very rare indication. And again, there's an indication for stent before a definitive procedure. So coming to the gold standard procedure, Piloplasty, a little about the history of the Piloplasty. It was started way back in 1886 by Trendelenburg. He first did a dismembered Pyloplasty. He just transected the UPJ and anastomosed. Of course, it again got stenosed. The Kuster modified this technique by dividing the ureter and re-anastomosed to the renal pelvis. It's called Kuster technique. And Fenzer in 1892 applied the Henke-Mikulix principle to the UPJ. So he incised the UPJ vertically and closed it horizontally. Again, it did not work because there was some buckling and the drainage was not proper across this horizontal suture line. In 1916, Schweizer described a YV Pyloplasty, which was later modified by Foley, and it came by the name as Foley YV Plasty. So it was in 1949, after Nesbitt Nesbitt modified the Kuster technique, which was further modified by Anderson Heinz, and it became a standard procedure for Phyloplasty called a dismembered technique. What Anderson Heinz did, how they modified Nesbitt or Kuster technique is, they spatulated the ureter and they made the anastomosis dependent and a funnel shaped. So that's how the results were better, and it came to be known as Anderson Heinz dismembered Pyloplasty. In 1950s, the flap technique came, flap techniques like Culp, Deward, and Scardino-Pence. So what are the principles of uretropelvic anastomosis? The anastomosis has to be widely patent, dependent, funnel shaped, watertight, tension free, with good vascularity. So what is anesthesia? All these procedures are done under general anesthesia. How do we position the patient? It depends on what type of approach you're doing, whether open surgery or lap surgery. If it is an open surgery, lateral child almost 45 degrees position. You don't keep the child in vertical position. In adults, we keep them in the lateral position. And in incision, if it is an open surgery, in infants, we give a subcostal incision over the PUJ, subcostal 3 to 4 centimeters incision. In adults, it's a standard extraperitoneal either rib cutting approach or a non-rib cutting approach. In laparoscopy, again, the trocar placement is standard. We need a 10 mm camera port and 2 lateral working ports, 5 mm. And the salient features are, you have to tailor the redundant pelvis. And the point of caution is, if you tailor excess, suppose there's too much of tailoring again, there's a syndrome called small pelvis syndrome. And after the stent removal, the patient can complain of pain because the kidney is not accustomed for the small pelvis. It is described as small pelvis syndrome. And what suture material we use, it depends. The suture from 40 to 70, especially in pediatric age group, we use the 60. I use a 60 PDS. And the continuous or interrupted, again, both are acceptable. When we do open surgery, we were doing an interrupted. Continuous suture is very much acceptable. And a drain, placement of drain helps in taking care of any small leaks. So to put a stent or not during pyloplasty, the pyloplasty can be performed without stent also. So the points in favor of stenting are, it protects anastomosis when there is edema or when there is inflamed mucosa or bleeding at the anastomosis. And urine leaks are definitely less when we put a stent. Why no stent? Because the stent has got certain problems like stent-related symptoms, and especially in pediatric age group, you need to give another anesthesia for stent removal. So this is a paper where they have compared stent versus external stent. External stent is we put a nephrostomy, and it's actually called a splintered anastomosis and stentless procedures. This is a meta-analysis of the 3 types of procedures. The DJ stented patients and the external stented procedures were associated with the more post-operative pain than the stentless procedures. But the DJ stent procedure has lower urinary leakage than those with the external stent or stentless procedures. So now it has become, in most of the cases, stent pyloplasty has become a standard. So there is no controversy in certain conditions. You have to stent. What are those cases? When we are doing a redo pyloplasty, when you are doing a pyloplasty in a solitary kidney, and when you find that the pelvis is friable, inflamed, and the hugely distended renal pelvis, all these cases, it's always put a stent. And of course, the stent is not a panacea for a technically bad anastomosis. You do a bad anastomosis and the stent will not take care of your anastomotic problems. Dismembered pyloplasty, it is applicable to different clinical situations of the UPJO. Most widely used technique, it permits the reduction of the redundant pelvis, which is not possible with the flap or the YV plasty techniques. It allows straightening of the tortuosity because you are dismembering and we can release the tortuosities of the proximal ureter. It allows transposition of the crossing vessels. If the vessel is anterior to the UPJ, compressing the UPJ, transit the UPJ, transpose the UPJ over the vessel. That means the vessel becomes posterior. It allows complete excision of the abnormal PUJ. So this is how the technique goes. When we do open surgery, you put for landmark, these are the medial suture on the ureter, and one suture in the upper part of the pelvis and one suture in the lower part of the pelvis. Excise the obstructed segment, spatulate the ureter laterally, and you do a proper, widely patent dependent funnel-shaped anastomosis. Coming to the other techniques like vertical flap. When do we do these flap techniques? When the obstructed PUJ segment is long segment, UPJO with a long segment narrowing, we can take a flap like this, vertical flap, bring it down, or you can do a spiral flap, a long segment narrowing, and bring it down. These are the flap techniques for a long segment narrowing. So for coming to Foley YV plasty, when do we do this Foley YV? When you come across a UPJ where it is a high insertion, inserting high up. Normally it inserts here, suppose high insertion, give a incision and extend the Y part like this, and make the YV. These are for YV plasty. I'll just show a small video clip of a YV plasty in a female patient who has got a horseshoe kidney with the stones with a bilateral UPJO. So see, there's multiple stones on both sides. Horseshoe kidney with a bilateral UPJO. Linogram has confirmed obstruction. So a laparoscopy was done. This is the IVU, sorry, the RGP films. The standard port placement. So the PUJ segment is identified. You can see the ureter there. High insertion. This is the lower pole. And you can see the isthmus here. So that is the isthmus of the horseshoe kidney. So these are all the pelvis here. The pelvis is coming. So we took a stage suture. This is, as I've told you, the technique of. So we are incising making the Y. The long limb of the Y is extended across the obstructing segment into the normal ureter. And the two limbs of the Y are made and it pulled down. Those are the two limbs of the Y. And this, now the Y is made V. There was a stone which was removed. I'll just run forward. Okay. So the anastomosis is completed like that. Posterior wall is being sutured. This will be followed by anterior wall. So this is the completion of the posterior wall. Stent is placed, and now the anterior wall is being sutured. The same procedure was done for this patient a month later, because even the other side also had got a high insertion PUJ obstruction. The completion. The right side, you can see, this is the ureter, high insertion. This patient has multiple stones. So again, the Y is being made. We should be very careful when we do this, because sometimes the incision can go into the infundibula. So you should not injure the calyces. Under vision, see, the calyces are very close here. The flap, the Y limbs are made. Stones are removed. And there are stones for many, the big stones for that. We have to use intracorporeal lithotripsy, pneumatic lithotripsy to remove the stones. So through the laparoscopic port, the lithoclast was passed and the stones were broken. The same procedure what we did on the right side was the left side was repeated on the right side. This is the Foley YV plasty. Posterior wall is being sutured. I think I'll skip this. Stent is being placed after the completion of the posterior wall. Now the anterior wall is suturing is done. This is a complete anastomosis. Stones are removed. So another procedure which is described the Hellstrom procedure. It is done when we think that the crossing vessels are the cause. When the PUJ is normal, the crossing vessels are the culprit. The grossly normal appearance of the ureter and the UPJ, the crossing vessels are completely mobilized. They are displaced with cephalad and they are fixed with the intracorporeal. You can see here in the picture, the vessels are displaced up and they are fixed so that they will not come again and impinge on the UPJ. The other procedure is Electrocalycostomy. Usually it is done after multiple failed standard Piloplasties in the long segment and the thinned out lower pole calyx where the PUJ segment is transected at the normal ureter and the ureter is spatulated laterally anastomosed to the lower calyx. And in non-functioning kidneys, the cutoff of GFR is 5 ml in children and less than 10 ml in adults. In such cases, a nephrectomy is done. So a word about the UPJ with secondary calculi. We can do a PCNL with endopyloptomy, as I showed earlier, or Piloplasty with stone extraction. There are different methods of stone extraction. We can use an nephroscope. You can use an intracorporeal lithotripsy if the stones are big. The lithotripsy can be passed through the laparoscopic trocars, or a lap-assisted PCNL also can be done if the stones are not accessible. Use of fluoroscopy always facilitates the stone clearance during the procedure. So a small clip about the robotic Piloplasty. This patient has got, see, crossing vessel here. Crossing vessels are impinging on the PUJ. These are the crossing vessels. So this clip shows how the vessels are, the PUJ is transposed. Completely transected. Now it is being taken from below the vessels. You can see here, from below the vessel, the ureter is taken up. The vessels have gone down now. Now the ureter is spatulated. A word about the suture taking here. If you take a little away from the corner, that will open up the these areas, pelvic ureteric area, and make the anastomosis a little more patent. So that's how we take a suture little away from the corner. This is the first suture, is a very important suture. So the posterior wall is being done. This is a transmesocolic pyloplasty in a child. You can see here the colon is there. We have given incision in the mesentery, and the pyloplasty is done. This is a transmesocolic. Usually it can not possible in adults, but commonly done in children. So now once we finish the posterior wall, guide wire is passed through assistant trocars, assistant ports. The stent is being placed, and then the posterior wall, anterior wall of the anastomosis will be completed. The anterior wall is being done. Once the anastomosis is completed, we can close this mesenteric window. The mesenteric window is being closed. This is a transmesocolic pyloplasty, robotic pyloplasty. So this is the paper where they have compared whether in children, whether laparoscopy is better or robotic technique is better. They say that because of the smaller working space in children, and laparoscopic pyloplasty has got advantages over robotic. Robotic assisted laparoscopic pyloplasty had longer duration of surgery and higher complications. The small workspace in infant can significantly limit the mobility of robotic instrument and increase the chance of port side conflicts. So the use of larger robotic ports and instruments in the smaller space of infant abdomen might have been responsible for higher complications in this meta-analysis. So now, having done the procedure, how do we follow up these patients? There are no definite guidelines as to how long we follow these patients after pyloplasty. Suppose you do a surgery, it is successful at 1 year, how long we follow? This is a paper from SGPGI, where they have followed these patients. What the conclusion is, after pyloplasty in children with a baseline GFR of more than 30%, if a diuretic renogram and ultrasound done after 3 months post-operatively shows non-obstructive drainage with a T-half less than 20 minutes and decreasing hydronephrosis, no further follow-up is required. So this is what the conclusion of the paper. So at the end of 3 months, if one renogram shows all normal parameters, you can stop doing a renogram in the follow-up. So, but some studies say that we have to follow up these patients at least for 3 years, because most of the failures, if at all they occur within the first 2 years. And longer follow-up is mandatory when we are dealing with the solitary kidneys and in a difficult anastomosis. So how do we follow up? In the follow-up, we see for clinical symptoms, that the patient has any symptom, presence of pain, and ultrasound, if the increasing hydronephrosis, increasing renal size, and if you do a Dtpa, worsening function or upgoing curve, all these point out towards a failure or a failed pyloplasty. So what is the definition of successful pyloplasty? The trifecta of successful pyloplasty are objective improvement of the renal function on a renogram, resolution of the symptoms, and no need for the repeat procedures like stenting. The patient needs the stenting after surgery, that means it is a failed pyloplasty. Absence of repeat procedures, all these things contribute are called as trifecta of pyloplasty success. So what are the complications of pyloplasty? Early complications like bleeding, surrounding with bleeding can occur because of injury to the renal vessels, crossing vessels, surrounding visceral injury, infundibular injury. If you do extend the tailoring of the pelvis too much inside, you can injure the infundibular or extend the calyces, injury to the crossing vessels, urine leak, and late complications like recurrent obstruction, infundibular strictures, ureteric strictures, these are all the late complications. So pyloplasty failures, as I said, failures do occur. Most of them occur within the first 2 years. How do you define a failure? Persistence of pain, persistent sequelae of obstruction like infection, stones, rarely hypertension, continued decline in the split renal function on renogram, increasing hydronephrosis, or a combination of the above. They define as a pyloplasty as a failed pyloplasty. So are there any risk factors for pyloplasty? Can we predict preoperatively or based on intraoperative findings that this patient is not going to do well? There was a paper where they have assessed the risk factors for a failed pyloplasty. One of them is a poor preoperative split renal function. So in one of the renograms I have shown, the preoperative renogram itself was showing a flat curve. The kidney was poorly functioning. So in those cases, Even if you do a pyeloplasty, the function is not going to improve and the pyeloplasty may fail in those patients. But again, there is a conflict of, there are some papers which say against this also. Patient age, early urine leak, presence of renal stones, abnormal renal histology. We'll discuss one after the other. So preoperative split renal function, more than 30% has a success rate of 90% after pyeloplasty. Less than 30%, the success rate is only 58%. This is a paper where they have said like this. And there is a conflicting evidence in the literature on the association of preoperative function and the pyeloplasty success. Prior endopylotomy. So endopylotomy not only has a lower success rate as initial treatment, but when failed, it can significantly diminish the success of salvage pyeloplasty. Early urine leak. Urine leak implies the suboptimal anastomosis and it can incite fibrosis. So it can cause tissue ischemia. So urine leak can stimulate fibrosis and the anastomosis leading to stricture. Histological abnormality. So reduced number of glomeruli, glomerular hyalinization, cortical cyst, interstitial inflammation. All these imply an increased risk of failure of the renal unit despite a technically successful pyeloplasty. So renal biopsy at the time of pyeloplasty can correlate with the preoperative and the postoperative differential renal function. So I think these people can read this paper where they have analyzed all the risk factors and the management of options for a failed pyeloplasty. So how do you treat a pyeloplasty? Then again, we have two options, endopylotomy or a salvage pyeloplasty. Salvage pyeloplasty again can be open or laparoscopic. So endopylotomy after a failed pyeloplasty, the success rates for a secondary endopylotomy are lower than that of a secondary pyeloplasty, ranging from 66 to 87%. So secondary endopylotomy is less durable than secondary pyeloplasty, as failure tends to occur within a shorter period. The success rates are improved by proper patient selection, particularly omitting the patients who have got a crossing renal vessel. So the success of salvage endopylotomy can also be enhanced by placing pre-stented patients. So the segment can be dilated and a proper endopylotomy can be done if these patients are stented before a salvage endopylotomy. So salvage pyeloplasty versus salvage secondary endopylotomy. There are no randomized prospective head-to-head comparisons, but there are two large retrospective studies in the literature where they have said that the subjective success is higher for salvage pyeloplasty compared to endopylotomy, 87% versus 74%. The trifecta is also higher for salvage pyeloplasty compared for a endopylotomy. So this is a literature review. In these two papers, you can see here they were compared endopylotomy versus salvage pyeloplasty. Endopylotomy has a success rate of 44% compared to a salvage pyeloplasty of 87%. So the management options for a pyeloplasty failure are a minimally invasive salvage pyeloplasty is a gold standard treatment for a recurrent UPGO given its high success rate. A secondary endopylotomy is an acceptable alternative, although the success is lower than salvage pyeloplasty. Electrocalycostomy is another option as a highly selective procedure, especially in a multiple reoperated case. Electrocalycostomy is an option, and nephrectomy has to be considered when the renal unit is non-salvageable. So coming to the take-home messages, UPGO is the most common cause of postnatal hydronephrosis. Diuretic Clinogram is the most commonly used diagnostic tool to assess the obstruction. You should be able to read the Diuretic Clinogram, all the components of Diuretic Clinography. The aims of treatment are to prevent deterioration of the function and relieve the symptom. Among all the procedures, Piloplasty, especially the dismembered Pyloplasty, has the highest success rate. The minimally invasive surgery has similar outcomes compared to open surgery. Nowadays, the minimally invasive surgery has taken over the traditional open surgeries. There is no clear consensus on follow-up. However, a 2 to 3 year follow-up with ultrasound and a diuretic Linogram will diagnose majority of the failures. And patients who are on conservative management need a rigorous follow-up to identify the worsening of the renal function. Salvage Pyloplasty has got a high success rate for failed Piloplasty compared to an endopylotomy. Thank you.
Thank you, Surya Prakash. Now, I'll just go to the chat box. There's one question coming up. Okay, so minimum age of Piloplasty in infants.
There is no minimal age. The minimal age for Renogram is there. You do a Renogram or even at the age of 1 month. We have to see the deterioration of the, if there is a deterioration of the renal function.
This probably is
Your voice is not clear, sir.
Yeah, you read the question. The question is, what is the minimal age of Piloplasty for infant? So this is probably related to the postnatal evaluation of antenatal PUJ.
Yeah.
So if you have a case for a patient with persisting postnatal hydronephrosis and you have done a diuretic clinogram, say after 1 month, and they have picked up PUJ, function is, say, assume you have 45% or less than 35%. So they want to know at what minimum age Piloplasty can be offered in both the scenarios.
Piloplasty can be even in the neonate. If you find that the renal unit is already compromised, there is no lower age cutoff. It can be done even a day's child. If you do confirm the obstruction in a month old, suppose you do a renogram at the 1 month age, and if you find the differential renal function is less than 30% and the thinned out parenchyma, so we can operate the child even at that age.
Okay. So the second question is from Mujahid. He has asked, how is the butler Pyroplasty done?
I'm sorry, sir, I'm not aware of this butler's Piloplasty.
Pyloroplasty. I think I'll put it to back to Dr. Mujahid if you can type the question again. Okay, I'll come back to the very important question, which sometimes is asked from students, that you have a PUGO and there's a borderline function, or there's some situation where you want to be very sure whether to do Pyloroplasty or nephrectomy. So, role of PCN in this situation, and if PCN is put, what are you going to see in that PCN?
Yeah, as I already said, we can evaluate the urine output, see the functions of the kidney like acidification and concentration. Acidification is known by measuring the pH, and concentration is by knowing the specific gravity. So these parameters help us in deciding, especially in pediatric age group, whether to salvage the unit or not. If after doing the PCN, because when you do a PCN, you're decreasing the pressure in the system. So majority of these kidneys improve, borderline kidneys, they improve given period of time. The concentration and the acidification functions improve. In such cases, we can salvage the kidney. Suppose even after doing PCN, there is not much of improvement, the output is not increasing, the kidney is producing a dilute urine and alkaline urine, there is not much of acidification, then we can go for nephrectomy.
Okay, Surya Prakash, one more question that is from our Dr. Lieutenant Colonel Muhammad for PUGO, and especially he wants to know how you will place your ultrasound and Linogram timings.
So 3 monthly, so there are no definite guidelines. I have shown you one of my patients. So we did a renogram at 4 months, and the obstruction was there on the diuretic renogram, then repeated at 7 months, and it was still persisting, then we operate. If there is a deterioration of function at 3 monthly intervals, you can do an ultrasound renogram at 3 monthly intervals. If there is a deterioration, then we can operate.
Okay. Another question is on the doubt of you have a stone and you have a hydronephrosis and you have dilated extranephrosis. So they want to know whether it's a PUJ because of the stone or it is a primary PUJ with stones. So again, this is again a question, a favorite question for the examiners. Yeah.
So obviously, it's a PUJ causing stones. The secondary stones are the round stones. They are not at the PUJ. They will be moving, wandering stones. That means the stones are secondary to the UPJ. If the UPJ is due to the stone, that means stone causing UPJ. Usually the stone is impacted at the PUJ, and you see the PUJ area is inflamed. The stone doesn't move, and even it is difficult to pass a stent if the stone is causing PUJ. And the UPJ is causing stones. You find stones in calyces, in the pelvis, round stones which are moving. The typical secondary stones. You can, looking at the X-ray, you take X-ray and consecutive days, you see the position of the stones keep moving. So they are secondary stones.
This question from Dr. Sumant. If you have maintained renal function and the hydronephrosis is increasing, what is the follow-up? How you?
Is there any?
Yeah. So follow-up renogram is unobstructed and hydronephrosis is increasing. So is there any cutoff value for AP diameter?
So AP diameter cutoff is basically we take this AP diameter in pediatric age group. 10 mm AP diameter is not one of the parameters. You have to take all the parameters into consideration. You just can't go by one parameter. Sometimes you can find a large extrarenal pelvis without unobstructed. In such cases, you can still manage conservatively if the function is maintained on renogram. If the renogram shows obstruction and associated with the increasing APD, there is an indication. You can still follow up the child if there's a mild increase in APD but preserved unobstructed drainage on renogram. It's a case for conservative management.
Absolutely. So, another question from Dr. Mujahid. A stone at PUJ leading to hydronephrosis, should we do DTPA or DMSA? So probably he's looking at a scenario where is a very dilated system and probably parenchyma thickness is reduced. Yeah. So he wants to know that whether it should be DTPA or DMSA.
The DTPA will tell you about the GFR. Suppose you want to know whether to salvage the kidney or do a nephrectomy. DTPA would be a better investigation. And one word of caution is, if you find an impacted stone at the UPJ, when you do a renogram, do not do a diuretic renogram. So when you give a Lasix in obstructed system, there can be a leak, pyloplasty can be there, Pyloroplasty, and that can cause problems. So you do a DTPA renogram without a diuretic in such cases.
Dr. Pankaj has written his comment, if there is a stone at PUJ causing hydronephrosis, do not diagnose as a PUJO. He wants to have your opinion. Sir. Do you concur with his opinion?
I agree with you, sir. Stone at the PUJ, we have to be a little careful if the stone is impacted, and especially in adults. So maybe we can remove the stone and do a renogram and follow up the patient. Or if there are classical secondary stones, then stone removal can be done by renogram, followed by renogram.
Because this is a common scenario which you face when you are doing a lot of stone work, and this is one of the scenario where you are not sure PUJ, but I think both of you are concur with the same idea. And I also believe that it has to first you have to clear the stone and go ahead with the further investigation towards the PUJO. Dr. Surya Prakash, you have put one slide. This our aortic pressure, and this is it perfusion or pressure? AP, RP, and SP.
The pressures, perfusion. Sorry, you can also measure perfusion. Perfusion. That is perfusion.
Yeah, it's perfusion. You are talking about pressure. So this is a perfusion. You showed the poor perfusion pattern of.
Yes. What they measure, the counts the time activity curve of the uptake, like what we measure in function, the time activity of the perfusion.
And
counts.
Yeah. So the other question which residents are often asked, the crossing vessels. So what is your opinion? These crossing vessels should be placed anterior to the UPJ for obstruction, or they can be posterior also to cause obstruction?
Posterior crossing vessels also can cause obstruction, rarely. But common scenario is we see vessels anterior causing obstruction. And I personally do not go for this Hellstrom procedure. If you find a crossing vessel, dismember and transpose it posteriorly. Because as I shown in one of the robotic Piloplasty, the PUJ was absolutely normal when we transected. It was normal, very widely patent PUJ. So vessel was crossing. So we had to transect and transpose the vessels.
Okay. Dr. Surya Prakash, another scenario, you have a bilateral PUJO and you have got, say, IVU or CT urogram done. So would you like to do nuclear imaging in these patients, or you can plan your management based on this imaging only? Contrast
bilateral
PUJO.
Bilateral UPJ, the problem is you may not get a differential renal function, but obstruction can be documented if you do a renogram. Differential renal function can be a little problematic in assessment if both systems are affected.
Okay. But so what is the creatinine, what you can say the maximum creatinine till what time you can order for nuclear imaging or the diuretic renogram? Till what creatinine?
We can do up to, I think, 3 milligram per cent creatinine we can do a diuretic renogram.
And do you have
exact cutoff?
And do you have any this our choice that if the function is low, you will do EC, otherwise you will do Dtpa?
So obviously, when the function is less, we prefer to do a EC or a MAC3. MAC3 is not available. EC is preferred over Dtpa because the extraction ratio is more with EC. It's more about 50% compared to DTA, which extracts only 20%.
Another question, this is again asked by the examiners. You have a PUJ with decreased renal function and nephrectomy versus putting a PCN. So how you deal with this type of situation when you have a, say, a child with a PUJ, other kidney is normal, you have 15% function coming on that, or 20% function, how you deal? Child and adult, both scenarios.
In child, we always err on preserving the kidney. So if a pediatric child comes with a grossly hydrated thin node parenchyma, we can put a nephrostomy and assess the renal function. And as I said, we see the functions of the urine, quality of the urine, concentrating acidification functions. In adults, I think if the GFR is less than 10 ml, probably we may go for nephrectomy rather than. I mean to say is we try to preserve the kidneys in a pediatric age group compared to adults by putting a nephrostomy.
This question from Dr. Suraj. If you have violet PUJ, which side you will operate first?
So I've done recently one case, bilateral PPG done simultaneously. So that is also a possible. Laparoscopy you can do simultaneously, but if you're not very confident, better functioning kidney always takes a precedence.
Yeah, Surya Prakash, I think we have done with the questions on the chat box, but I think a couple of things which you mentioned very nicely is the one point that if ureter is seen on IVU or CT urogram, it should not be mentioned that there is no PUJ, because the majority of the students, the ureter is seen, it is a normal PUJ. So it is a partial and intermittent obstruction. So ureter will be seen, and this is not a total obstruction. So it's a very, very important point. And your other thing which you are telling that you have to read the diuretic clinogram. So this residents usually should make a habit of reading the diuretic clinogram from top to bottom. So that means there will be a first mention of line which protocol they have done. Then there will be mention about how many millicuries of what isotope has given at what interval of Lasix. Then there will be left kidney or right or left. Then interpretation will be given and further diagnosis. This is the way examiner will be asking you in the exam.
Yes.
So it's better to read all the report of all the investigations, whether contrast or nuclear or ultrasound, thoroughly from top to bottom. This will give you a practice how to pronounce in the exam. This is very important. I think Dr. Surya Prakash, you have...
There's one question Dr. Chandramohan is asking, sir. Should we do a Dtpa of every antenatal hydronephrosis postnatally if AP diameter is decreasing? So not mandatory if the renal architecture is normal, hydronephrosis is decreasing, we don't do a Dtpa renogram. Compared to antenatal, postnatal, is a decreased hydronephrosis.
No, his question is if AP diameter is increasing.
He said is decreasing. AP diameter decreasing.
I think it should be increasing.
Increasing we do. Increasing we do. Definitely.
Yeah. I think decreasing is answer is clear. It should be increasing whether it should,
Yes.
Okay, and yeah. So with this, I think I should thank the members who have asked questions, including residents. And I think Dr. Pankaj Mishra, you have to make any comment how?
No, sir, I think it has been a wonderful compilation and a brilliant talk. I compliment Dr. Surya Prakash.
Thank you.
Everything has been covered beautifully, sir.
Yeah, I totally agree with you. Very, very, very nicely covered, and so many points which he covered are relevant to the examination which you will face couple of months or maybe next year, whenever you are facing, and which has been nicely covered. I think a few doubts are there regarding the postnatal hydronephrosis. I think we have a separate class on the postnatal outcome and management of antenatal hydronephrosis. Probably that will be clearing all your doubts. With this, I think on behalf of Indian School of Urology and USI, I take a great pleasure in thanking you of being a faculty and covering nicely the topics, clearing the doubts of all the residents. And I thank all the members, including Dr. Pankaj, who have joined in, residents who have spared to attend this class. I think again I urge you to join all the classes. Probably before exam, we are planning to have a mock exam that will be virtual, which will cover important case discussion as well as brief talks. We'll let you know by sending a notice to all the residents on the mail. Thank you very much, Dr. Surya Prakash. Thank you, Dr. Pankaj. Thank you. Bye.
Thank you. Thank you very much. Thank you. Thank you.